Nurses give this. PITT, stop this nonsense of doctors giving medications. You're a one-stick wonder. Dana, don't touch that ET tube. But it was missed. Come on, guys. You chose not to CT them because you're dumb. Let him have it, Dana. I've never watched that, by the way. Actually looks pretty good. Don't take out the ET tube. Which vitamins? We don't order those in the ER. I love a good LaCroix. Oh, I will destroy this case. Just a TV show, but man, that gets you. Welcome to Dr. Taylor Reacts, the channel bringing you the most extensive reviews of the PITT on YouTube. Next up, episode 6. Let's go.
I'm in. Bag 'em.
Defib pads are in place.
Okay, holding compressions.
Good square line on the end-tidal CO2.
Defib. Charging 200.
Charge.
Case is so sad.
Clear.
Stand by with Epi.
No, give Epi.
Section that too. Not in the esophagus, sorry. Definitely not. I passed right through the cords. Good breath sounds. End-tidal CO2 confirmed.
His lungs are filling up with blood.
I know.
Okay, so I will say sometimes when patients come into the ER in cardiac arrest, depending on the cause for the arrest itself, they can have so much blood in the lungs that the moment you intubate them, literally I've been like part of so many cases where you pass the 7.5 ET tube in, and as soon as that tube is in, it starts pouring out blood out of the top. You're trying to suction it so you can attach the bag so you get this oxygen going because the patient is clearly hypoxic and blood is just pouring out. You're trying to catch up with the oxygenation. You're trying to like ventilate them and they have all this blood just pouring out. So I've been a part of a lot of cases like that and the patient just comes in arrest. So I'm not sure in this case what the cause of the cardiac arrest is, but so far the initial rhythm we had was ventricular fibrillation that they shocked at 200 joules. I agree with, this is a shockable rhythm. I will say if you remember at the end of episode 5, Louis was unresponsive and he had no blood. Zero blood on his face, his chest, his abdomen, not even a speck of blood. It was clean. So far, it's actually the one thing that does not quite make sense. This is a patient with liver failure. Their INR is potentially high. It's super therapeutic. It's 4, it's 5, it's 6, it's high. They're prone to bleeding from multiple sources. If that much blood is coming out of the ET tube, with his history, the worry at this time is this pulmonary hemorrhage from hepatopulmonary syndrome would be one of the many possibilities. Hepatopulmonary syndrome is a result of long-standing liver failure. Basically, you have these dilated, fragile vessels that rupture. Literally, the lungs fill up with blood and the patient suffocates in his own blood. The lungs just fill up with blood. Now, if that's where this is going, just realize though, hemoptysis is going to happen first. You're not going to drown in your own blood with zero blood coming out. All the cases I've been a part of like this, they're going to have a speck of blood at a minimum, but in general, they're going to have pretty significant amount of hemoptysis. At least at the very beginning, you're going to have a little bit of hemoptysis, but this is going to result in massive hemoptysis before the arrest. You're not going to go from nothing, no blood, nothing, to just arrest. Now, some people could say, well, the patient's, all the lungs are going to fill up and it's just going to fill up so fast, he's going to suffocate and die. You're going to start coughing up blood before that point. And so if that's where they go with this, it doesn't quite make sense because where was the blood at the end of episode 5? And if that's the case, and the makeup crew really kind of got this wrong, you won't see a pulmonary hemorrhage cardiac arrest with zero blood on the mouth, zero blood on like everything, like nothing. They're going to start coughing this up as they drown in their own blood.
Okay, rhythm check. Asystole, push the epi.
The initial rhythm was V-fib, and now it's asystole, so that is a flat line. The arrest has only been going on for essentially a minute. If you recall at the end of episode 5, the alarm went off. As soon as the alarm went off, the staff went in the room. That is at the end of episode 5. They responded right away. In the setting of massive hemoptysis leading to cardiac arrest and now asystole, that mortality rate is high.
Patients with lunch trays have been admitted. They're boarders. They're waiting for a bed to open upstairs.
What about the others?
Non-admitted patients. They can have sandwiches or juice boxes. Just make sure they're not NPO. It's nil per os. It's Latin for nothing by mouth. NPOs are waiting for surgery. They'll beg, spit, and curse for food, but you gotta stay strong.
Hey, I've been waiting for an hour. When am I gonna see a fucking doctor?
Excuse me! Perhaps you didn't see this, which is strange, because they're all over the place. Aggressive behavior toward healthcare workers is a felony.
Let him have it, Dana.
$2,000 fine, possible jail time. Got it?
Okay. I was just asking.
We're busy today. It's a holiday weekend. We see the sickest patients first, so be happy you're still waiting.
Stuff like this irritates me. This happens and it should not. What pisses me off in patients like this is that, at what point do you say to yourself that it is okay to grab somebody like this? It doesn't matter, if this is a patient, to do this in general. At what point would you be like, it is okay to do this? I'm not getting seen fast enough. Let me just go grab a tech, grab a nurse, grab an ER doc. At what point do you tell yourself this is okay? How does someone have to be at this point to think this is okay? This is very realistic for the PITT to do. This happens, and this should not happen.
PTMC charge nurse. Go ahead, medic ma'am. Okay. Got it. Incoming trauma. Come on.
3 minutes since last epi.
Full compressions. Asystole. Resume CPR, another AMPA epi.
Use my section.
The episode has been going on now for 2 minutes. The arrest started at the end of episode 5. We are now 2 minutes into this, and we just hear 3 minutes before the last epi. So already that timeline does not add up. I don't want to spend a lot of time critiquing that because I've said this throughout the last episode, really in season 1 as well, going all the way back, that everything is rather the progression of everything is escalated quickly. The diagnosis, the progression of treatment, everything is escalated. Things are happening quicker. They're speeding it along. Now, I will say if you speed it along enough, it becomes unrealistic. I'm only pointing it out here because the timeline doesn't quite add up with what they're saying with epi, how long it's been going on for. Realistically, Louis has been in cardiac arrest at this point for maybe 3 minutes, assuming when the alarm went off initially, that was the immediate response. Now we're in asystole. What I do like about this is that they didn't shock asystole. This is a flat line. This is a non-shockable rhythm. We see in medical dramas often where there's a flat line. They're like, shock them. And you're like, come on, dude. You could argue, okay, it's fine V-fib. All right, put an ultrasound on the chest. Let's see if that's truly a fine V-fib. You'll be able to see that on the chest on a bedside ultrasound with a cardiac transducer literally within seconds. But we know it's not the case in medical dramas. They're shocking a flat line because they don't have good consulting physicians. Now, the PITT nailed this scene, at least with the V-fib that was shocked, and now it is asystole, and they're not shocking asystole. That's awesome.
Pulmonary hemorrhage from liver failure.
Is he going to make it?
Yes, this is perfect pulmonary hemorrhage. I love this. Horrible diagnosis, but a great case. This looks legit. It's literally pouring out of the ET tube. You cannot put a trauma cordis in fast enough to deliver enough blood to replace what you're losing. You drop a femoral cordis, let's say you drop that thing so fast, you're a one-stick wonder, boom, you slide it in, cordis is in, you get that bad boy in, you start doing this massive transfusion protocol, you're not gonna get in blood fast enough for this massive pulmonary hemorrhage that is just pouring out. You cannot put in a cordis fast enough. His INR is likely high, it's 6, it's 7. Now you have certain blood products that you can administer, certain medications that you can administer, but in asystole, that mortality is high. I will say the only thing that does not make this diagnosis entirely add up, entirely accurate, is you're not just gonna fill up with blood. The lungs are not just going to fill up with blood, and you won't even have a speck of hemoptysis first. That is what would make this realistic. Like if they responded, they get in the room and he's got some blood all over his shirt, that's legit. That would be perfect. I think the makeup crew missed this. I don't know how the consulting physicians missed this. If you want to make this realistic, show me blood on the shirt, his mouth, something prior to that intubation itself. It's the one thing that made this not entirely realistic.
Should we get PCC?
Too late for that. And he's not an ECMO candidate.
Nothing else we can do.
No, I think we're done.
Louis.
$12.07.
Should we do a debrief?
We got another motorcycle injury coming in, ETA 10 minutes. When we get a little cleaned up, going to the VR wrap.
Yeah, anybody that wants to pay their respects can join us in there. Thank you, everyone.
It's so sad.
I'll clean them up.
Why don't you take 5 first? Or 10? Yep.
Okay, so they basically call time of death about 3 minutes into this episode, but noted 12:07 as the time of death. So it's super fast. That just means, 3 minutes into the episode is equivalent to maybe 7 minutes. So in real life, we're not calling it after 3 minutes. I don't think I have called a code before in 3 minutes, but that was because EMS brought the patient in and they were already dead on arrival, but got brought to the ER anyway. And so there are situations where you see the patient, you're like, rigor mortis has already been going on. It's like a nursing home patient. They've been dead all night. EMS, for whatever reason, you get like a new crew, for example, they bring the patient in and you look at the patient and you're like, rigor mortis has been going on for a while. And the same thing happens, like SIDS, for example. We'll see all of them in the ER, but they'll come in, CPR in progress, down, let's say they're down the whole night. Family didn't see it till morning, and then we're getting this baby that comes into the ER and CPR is going on. You see the child, rigor mortis has already started. In situations like this, it's hard to say time of death. It's hard to stop, but you have to take a step back and be like, rigor mortis is already present. That is actually a contraindication to performing ACLS is when rigor mortis has already gone on. There's a few times where, we're just gonna stop. And sometimes it's hard to do that. You're seeing a baby on, right in the, like parents wake up in the morning, you had rolled on the kid. The kid's been dead all night. EMS gets there, they bring the child in. They intubate the child, or sometimes they can't because of the rigor mortis. And then we see the patient in the ER and you look and you're like, patient's mottled, rigor mortis has set in. And you're like, we're going to go ahead and call this, let's take a moment of silence. And so in the case of the PITT, 3 minutes is equivalent to maybe 7 minutes. I'm not sure. In reality, what really happens? Let's say you have a massive hemoptysis that arrives into the ER. Let's say they had an arrest. EMS lost a pulse in the bay itself. What's going to happen? That patient's going to come into the ER immediately. You're going to have a whole team that's going to be a part of this resuscitation. You're going to have somebody intubating. You're going to have IV lines going. Someone's putting in a cordis. You're starting the massive transfusion protocol. We're suctioning. We're trying to get all the blood. We're going to be given PCC that Langdon mentioned, that prothrombin complex concentrate, in addition to likely vitamin K. We're given this and this and this. We're doing everything all at once. Obviously, in this case, they didn't want us to see that with Louis because we want the emotional, everything emotional kind of downstream from this. And I'm guessing they're going to do a moment of silence and things like that. And so we want to see that with Louis because he has had a large part of the PITT in season 1 and now in season 2. So they have to come up with a way that's going to get us to that point. And I just think with escalating the timeline of everything, not including the blood, escalating the timeline, calling it in 3 minutes, not giving any other med, but yes, it has a high mortality, but if your timeline's not right, it's throwing everything off. And I think that's the issue with this case. This is basically a witnessed arrest. Assuming he went into arrest, the alarm went off, and everybody responded immediately. Mortality is still high, but we're not calling it after 3 minutes. My only critique. Now, if the arrest had been going on for 15 minutes, for example, prior to coming into the ER, an arrest outside the hospital, for example, sure, a round or two, and you're gonna call it, especially with asystole. But an arrest with an initial rhythm of VFib and you responded immediately, we're not gonna call it after 3 minutes. Are you kidding me? Mortality is high, we know that. But how the PITT presented this case with the timeline is what made this unrealistic and why I'm critiquing it so hard.
Ano nangyari?
Louis,
Patay?
pulmonary hemorrhage.
That was quick.
I'm gonna go clean him up.
I'll help.
Go. Okay, now.
Everything okay, Roxy?
I can't get off the bedpan.
Oh, that's what I'm here for. Your husband seems like a saint. How long have you been married?
Too long. Almost 20 years.
You put your arm around me, and I'll pull the bedpan on 3.
Okay.
1, 2, 3. One more. Great. 20. Wow.
Yeah. He's been by my side through all of this. I've watched the light go out of him. So have the kids.
That's what happened to my auntie when my Uncle Gerald got sick. But your husband does it because he loves you.
God, I don't know how you do it. Care for people day after day.
I'll tell you my secret. I go home at the end of every shift, leave this all behind, and escape to Love Island.
I've never watched that, by the
Go in
way.
here. The high demand dose of morphine helps
keep
a little,
hearing
but
about
she's
this,
still
though.
in pain.
Okay.
I got your order. 0.1 per kilo.
Thanks. This is a very low subdissociative dose of ketamine. You might feel a little weird, but I think it's going to help with the pain.
Is my husband still in the cafeteria?
I think so. Want me to get him?
No. It's good for us to have a little time apart.
Get you another blanket.
Well, that's interesting. Subdissociative dose of ketamine. I guess, what's irritating throughout this entire series is we keep seeing residents giving medications. You're not going to see a resident giving medications at all. Now, I will say this is dissociative dose of ketamine. Now, in the ER anyway, if you're doing a procedural sedation, if you're a pharmacist, if you have an ED pharmacist, for example, they can administer, depending on your hospital's protocol. At one of the hospitals I work at, the pharmacist can actually give the medication, and then physician is doing the actual procedure itself. And so in this case, ketamine can be given by the ER doc, pushed by the ER doc. It's one of the medications that we can push. In addition to that, pharmacy is doing that. Now, this is subdissociative dose of ketamine, so it's a little bit different. If we're doing an intubation, for example, now the nurse is giving that ketamine. Outside of that, we would be doing it for a procedure, or pharmacy would be doing it. I don't know if this hospital has a protocol specifically for subdissociative dose of ketamine, but I'm pretty sure that a resident is not going to be given this medication. And we keep seeing this throughout this series of residents and physicians giving medications. That's crazy. It's 100% unrealistic. And we need to stop seeing residents giving meds. Residents do not give meds. Oh, here's one for you. Attendings don't give medications. The only time is that procedural sedation or even we're doing a laceration repair, for example. Now, even as an attending, I don't even give Tylenol. Tylenol, I don't even give. Motrin, I don't even give. Nurses give this. PITT, stop this nonsense of doctors giving medications.
Here, I'm headed that way. Thank you. Back here for good?
Officially out of triage. They need extra hands with all the Westbridge hullabaloo.
How many cups have you had today?
Don't judge me.
Just asking.
You're judging.
Did you hear about Louis?
No.
Pulmonary hemorrhage. Didn't make it.
Shit. Come on, he's been here 100 times.
I know. Debrief in the viewing room later. On a happier note, Pearlie and I are planning a birthday party for Giovanni. She's turning 21.
You two are thick as thieves. I don't have much of a social life these days, but I'll be sure to keep an eye out for the party.
Let's discuss our incarcerated patient, Gus. Prison infirmaries tend to be short-staffed, so we need to be thorough. What's in a differential diagnosis for malnutrition?
Inadequate intake, methamphetamine use, severe alcoholism, ADHD medication.
What else?
Cancer of the oropharynx, esophageal strictures, prior strokes, malabsorption, inflammatory bowel disease, none of which were in his medical record.
What about psychosocial causes?
Could be an intentional hunger strike.
Or refusing food to get to the infirmary.
Could also be abuse or neglect. Let's start with a nutrition history once he's back from CT.
Do you have a second to talk about Westbridge? Hey, we need to start moving some patients out of here. These walls are starting to fill up with gurneys.
Santos, Ogilvy, and King all have patients on the launching pad. I'll check in with them.
How many patients have we had rerouted from Westbridge?
10. God knows how many more in the waiting room. Ambulance will be here in a few minutes with the accident victim. I'll stick him in trauma, too.
What is the story with your incarcerated patient?
Gus Varney, 3 rib fractures with normal O2 sats currently, waiting on CT results.
Okay, if he's stable at the 2-hour mark, I'd say he's good to go. Let's get the ball rolling on discharge.
Let's wait on the CT results.
We can move him out of trauma 1 at least.
Yes, we can. What's open?
13 and 14 will be discharged soon. 15 once we can move Louis to the viewing room and get it cleaned up.
Our paracentesis patient, Mr. Cloverfield?
Lethal arrest. We'll do a debrief when we know how many patients we're getting from Westbridge.
So Gus goes to 13, 14, or 15.
I kind of want to keep him in plain sight. What about BH2?
Sold.
Why not give him some privacy? Everyone can see him in BH2 like he's a monkey at the zoo.
Because he came in with an orange jumpsuit, we need to think about patient and staff safety.
Safety first, bitch. 2 beats a prison cell.
Not by much.
Did you guys hear about Louis?
Yeah.
Chronic alcoholic? Go figure.
Hey, Fento D in South 20 is ready for discharge, but could you get Lupe to call him a ride? I need to check on Louis.
Actually, Whitaker,
He croaked.
What?
5 minutes ago, Robbie called it.
Can't stand that med student.
Yatang bagito.
He states, go figure, and then says he croaked. Seriously, come on, dude. This med student literally has zero compassion and frankly, does not belong in emergency medicine. Now, we already know there's gonna be a season 3. I try to stay offline with, any updates related to this series. I have not watched episode 7 yet at all. I am only up through, now, episode 6. And so I refuse to watch any further because I want to make predictions. I want to be surprised. I have no idea where this is going, but it's impossible to avoid the fact that they've been renewed for season 3. And we know that season 3 is going to happen sometime in this year because I'm going to be on the HBO Live podcast with that. And so what I can say is that because it's an episode, because it's in season 3, because it's this year, all the med students are in the same year, all the residents are in the same year. And so what that means is that Ogilvy is a 4th year. He's doing an audition rotation, which is a month-long interview. With his performance, he would not be given an interview. I can already tell you that. He would not be ranked at all. Someone like this, as a senior resident, we would all make sure the program director knew about it. Literally, after that student is done rotating, we're gonna go up to our program director and be like, hey, Dr. So-and-so, he's not good. We can't invite him back. Please don't give him an interview. Done. That's it. Ogilvy, you just got screwed because you screwed yourself. We wouldn't invite you back at all. And so I think if the PITT wants to make this realistic, they're not going to bring back Ogilvy at all because the timeline actually wouldn't make sense. You may say, well, maybe he came back for another audition rotation. No, you have a certain amount of audition rotations. You have a certain amount of months where you can audition. And some of these you're going to do 2 weeks, some are going to do 4. I don't remember how many 2-weekers I did, how many 4-weekers I did, but it was probably 2 or 3 of each. You're not going to do a lot of those. You're going to pick like the best programs, like your favorite programs, and you're going to rotate there. So for him to do a whole 4 weeks and not be good, and then all of a sudden come back in the fall, come back for Halloween or Thanksgiving, come back October, November, and do another 2 weeks, that makes no sense. And so I think anybody that says Ogilvy should return for the next episode doesn't make sense at all. The only thing I will say, a technicality, the only way that you could bring Ogilvy back is your 4th year, you have other rotations that you're doing. And so they could actually bring him back in terms of he's doing a rotation, like a different rotation at that same hospital in another specialty. And he just happens to make his way into the ER for a case and we see Ogilvy again. That will be 100% realistic because I did other rotations at the same hospital I did my audition rotation at. So that would happen, that can happen, and that would make sense. But outside of that, it wouldn't make sense for Ogilvy to come back for another 2 weeks or 4 weeks of emergency medicine.
I'm sorry, man. We didn't have time to find you.
What happened?
He was apneic and pulseless. We started CPR and intubated him. He had a massive pulmonary hemorrhage, Robbie called it.
And you don't know it was a pulmonary hemorrhage?
Found this with his stuff. Guess he was married at some point. Never knew that. Didn't miss this part of the job.
Yeah.
Perla, did Louis ever mention anything about a wife and kids?
As far as I know, he only had eyes for Rita Moreno.
This is not Rita Moreno.
No, it's not.
Can we check to see if there's emergency contact?
Yeah, there's a number listed.
You're his primary. Do you want to?
Yeah, no.
Is that him?
PTMC charge nurse. Langdon, where are you?
Man, that's sad.
Makes sense that we'd be his emergency contact. Sorry to get your hopes up. My social work is gonna do their thing. If Louis had any family left, they'll find them. Okay?
Guess it's good it happened here, not out on the street.
You're off the hook with Louis. I'm gonna teach Emma here how to clean a dead body.
I'm sorry, but they need me in L&D. You might want to call for another interpreter. Busy day.
Shit, that's our girl in 12?
She's been waiting for 5 hours. Didn't hear her name called the first time.
You check on her?
Need to brush up on my ASL.
You know sign language too? Princess here knows 6 languages.
I know French.
Okay, it's not a contest.
Je parle un peu français.
Ah, très bien.
No shit talking in front of me. You get enough of that from her and Perla. Guess I'll call for backup. Oh, yo, Donnie, did you discharge your butt abscess?
Not yet.
Oh, he is on a roll. Where's he
What the
going?
hell?
Your good friends upstairs sent donuts. Special thank you for working the holiday.
You gotta be kidding me.
What were we expecting? Tacos and tequila?
Every single one of them can forget about extra shifts. Won't hire more nurses.
Pays a decent wage.
Won't hire security that can actually protect us from patients, but absolutely send donuts.
Preach.
Sure you want to go into this line of work?
Want me to get you one?
Of course I do, but I'm not taking admins, blood pastries.
Absolutely love this. Regardless of where that food comes from, the moment it arrives to the ER, everybody is going to come get in line. When I buy food for the department weekly, rather this is pizza, it's Mexican food, it's burgers, it's donuts, literally anything. My latest was 300 wings for the entire department. This is your nursing staff, this is your techs, your physicians, this is security, this is even the psych side of things. Like, it's for literally everybody. It's like a watering hole. Everybody comes for food. For just those few minutes, you forget that you're working in the ER. Could be a minute, 2 minutes, but for that period of time that you're able to take down a wing or two, or if not, even more, you forget you're working in the ER. and then reality hits. And then you got to get back to the grind.
A two, Donnie? Okay, move it or
Actually,
lose
that's pretty
it.
good.
Meet me in South 15 with gowns and gloves.
Looks like happy hour in here.
Don't ask. What's up with Evel Knievel?
We are getting an EMS report. All right, we're going to see if this is solid. We're going to see if this is accurate. Fingers crossed, this is going to be a solid EMS report.
Brandon Lee, 52, fell off the motorcycle pyramid at 25 miles per hour.
Motorcycle pyramid? You recruiting? Got a fellow rider in your midst.
No kidding.
How high up were you?
On top of a 321, but the bottom guys are sitting down driving the choppers. I'm fine. I don't need all this.
Were you wearing a helmet?
Of course.
Oh, what do you know? They're still in style.
Good vitals, tender right wrist, and big left knee lack.
Hey, Joy, Perla, trauma 2?
Oh, you gotta be kidding me. This is an epic fail. Epic fail of an EMS report. 52-year-old fell off a motorcycle pyramid at 25 miles per hour. Started out great, and then we hear good vitals. Huh. What does good mean to you? As an EMS and fire department medical director in the Air Force, I will continue to call out this EMS report every time I see it on screen. EMS does not state good vitals. What does good mean to you? Let me rephrase. You have a motorcycle patient, regardless of them talking or not, they fell off a pyramid, they're placed in a C-collar, literally a trauma patient, and you could not even tell us the initial vitals on scene or any set of vitals at all. Poor form. Does the patient have a spinal cord injury? Their heart rate's actually, it's mildly low, but, vitals are good. The heart rate's actually 55. The MAP is technically above 65, but the systolic is 96. And it turns out, guess what? Normally, this patient's blood pressure is 180 and they don't take their meds. And they may be mapping 65, but their blood pressure is in the 90s. That's a relative hypotension. Like, that is hypotension. Something is going on. And I cannot stand when I hear vitals are good. I'm always going to ask, what were the initial vitals on scene? What were the last set of vitals that you had? All of the paramedics I work with will give us a set of vitals. They're going to give us an actual EMS report that is good. We're not going to see this stuff. Like, this is crazy. Poor form.
Sometimes it's worse knowing that there was nothing you could do. Are you?
Robin needs you both in trauma 2, and I need you to discharge Sweet Patty and 13 as soon as you're done. Can't catch a break. I push you because I know you can take it.
Only pausing here because Santos is behind on our charts, and I just want to clarify one thing. As residents, you have a certain number of ED shifts, so emergency department shifts that you do every single month. Like, if you're not doing an OB month or you're not doing an ICU month, if you're in the ER, there's a certain amount of shifts that you're going to do in that month. So first year of emergency medicine, like when you're on emergency medicine, you're going to do anywhere between 18 to 21 shifts, depending on your program. Some may actually do more than that. Your second year, you're probably going to do around 18, sometimes 19. Third year, you're going to do about 16. Your fourth year, you're going to do 14. If I recall, it was also my chief year. I couldn't remember if it was 12 shifts or 14 shifts. I lose track. It's been a while. The point is, the further you get along in the program, the less amount of ER shifts that you do when you're on emergency medicine. Now, everyone is obviously different, but you're going to do a certain amount of ER shifts. So as a second year, let's say she's going to do 18 shifts, maybe 19 shifts. The rest of that time, like, you have off. You're studying for exams. You're doing all these other things. But when you're on those shifts, you are on. There's zero distraction. You are on. The rest of the time, you could catch up on your charts, or depending on how far in your program you are, you can moonlight. And generally, Santos would not be approved to moonlight. I can already tell you that. She's only a second year, but with her education, training, and then of a 4-year program, she's not going to be able to moonlight. That I can tell you. My 4th year, when I was a chief, during my ER months, I think it was maybe 13 or 14. I honestly don't remember. But I would pick up moonlighting shifts at other hospitals as well. But all that to say, Santos being a second year likely does anywhere between 18 to 20. When you're on shift, you work, you chart, but you don't come to work and skip patients to chart. That's not how that works. If you are that far behind, this is a conversation you have with your program director. literally your program director. Now, Dr. Robbie is the medical director, and I want to be clear with that's not the same person. We actually have not been introduced yet to the program director for the residency, in addition to the assistant program director. So we have a few people that the PITT could introduce, and so you can even have a shift, let's say in the future, they really need a 2 attending, the shifts need to be 2 attendings. And so honestly for season 3, since we know, assuming Langdon returns, for season 3, if Langdon, obviously he's still 4th year, if the PITT decides to make this more realistic and bring in a 2nd attending, hey, let's bring in now the program director. He's going to work with Dr. Robbie. Or, you know, the night shift doc gets promoted to the assistant program director, and now you got Dr. Robbie, the medical director, doing a shift with the program director or assistant program director. Out of all the shifts that I did, probably some of my favorites were when you got to work with the medical director, or you got to work with the program director, or you got to work with the assistant program director. And my residency was a very large residency, and you're gonna have probably the most attendings on at one time in my residency was maybe 3 or 4. That's how large this program is. A lot of residents, and you're going to have 3 or 4 attendings on at one time, depending on the time of the day that it was. And it's like, man, if you could score a shift with all the good attendings, and then our program director was awesome, assistant program director was awesome, medical director was awesome. If you can score a shift with them, oh, dude, it doesn't matter what comes in that door. It's going to be a fun case. You're going to enjoy it. It's going to be great. It's going to be a great shift. If Santos is this far behind, then honestly, she shouldn't have done that shift today. Instead, you're going to make that shift up another day, and you're going to spend that day charting. It's not that she just doesn't show up. No, she should have already have had a discussion with her program director, assistant program director. Clearly, if Dr. Alashimi is aware of this and she's a new attending on her orientation shift, that means the program director should know. The assistant program director should know. Other people should know, and that's not the case here, and I don't understand why. If I was Dr. Robbie, she's not going to be seeing patients and continues to go about her shift, not seeing patients, woe is me, and clearly distracted with that type of attitude, I'm going to send you home. And I've probably only, over the years as an attending, it's always a weird thing to say because I've been practicing now for, since 2019. And so I think I've only sent home 2 residents over that period of time, and they're going to make up that shift a different day. I've only sent 2 home during that course of time. And I know some of my colleagues have sent 1 home here and there. Sometimes they get sent home early, like, dude, just go. And so this happens, and if she's going to be like this, she's going to be sent home, and it's going to be reported to the program director. It's going to be reported to the assistant program director. She's going to make that shift up another day. Simple as that. Oh, you're off Friday and Saturday? Boom, you're now working on Friday or Saturday. The good thing is, it's an easy thing to make up. You're on an ER month, you're gonna make it up. That is the part of the episode that's starting to not make sense in terms of how they're handling the chart situation. I understand why the PITT is doing this and the drama that we need to see, but I wanted to point out what's realistic and what's not realistic. You're not in the ER to catch a break. You're in the ER to work.
You ever clean a dead body? I've never seen one either. No one tells you what it looks, feels, or smells like, but you get used to it over time. We pull off the gown, wipe him down with towels, and we'll roll him on his side.
Don't take out the ET tube.
Clean his back, stuff the sheet under him. Wipe down the bed, roll him the other way, pull out the sheet, and repeat. Just follow my lead. Usually, leave the ET tube in for the coroner, but Louis is a chronic alcoholic with end-stage liver disease, not a coroner's case.
Oh, Dana, do not even touch that ET tube. It does not matter, chronic alcoholic or not. After a patient is pronounced in the ER doc is going to page the coroner. The coroner is going to call back. We're going to discuss the case. If it's a coroner's case, autopsy, everything is going to stay, including the ET tube. Literally, everything stays. If the coroner says, no, this is not a coroner's case, that endotracheal tube can come out. Likely, is this a coroner's case? Probably not. It still could be, but this is not Dana's call to make. I would argue, I think this would be a coroner's case. This was a patient in for, alcohol abuse, alcohol, now obviously when an alcohol withdrawal, we got to see it a little bit earlier when he's diaphoretic and everything. Now for the charge nurse to assume this is not a coroner's case, assume means ask of you and me, for the, her to assume that the coroner's case is not a coroner's case because he's a chronic alcoholic makes no sense. It's not realistic and it would not happen in real life. Dana, don't touch that ET tube. Speak with Dr. Robbie first. Find out if it truly is a coroner's case or it's not a coroner's case.
The social worker always tries to find them. Sometimes the family loved them, tried to get them to come home. Other times the family wants nothing to do with them.
That's sad.
That's life.
What happens if no one claims his body?
We'll be cremated.
Where would his ashes go?
Keep him for a few months, then he gets buried in a mass grave with all the other unclaimed bodies. Okay, now we roll him.
Yeah. Oh my God, is he still alive?
No, that happens. These frequent flyers. It can be a real pain in the ass, but you miss them when they're gone.
Been at every Millvale 4th of July parade since '08. World record is 40 men on 7 motorcycles. Plan to beat that someday.
Good lung sliding bilaterally.
Pupils equal and reactive. What do you ride?
Small detail here, subtle, but she used the wrong probe. Whoops, the transducer as Santos used is the abdominal probe. We actually use that for the FAST exam. Sometimes I'll use that for the cardiac exam, subxiphoid, depending on body habitus of the patient. The probe for checking lung sliding though is the linear transducer. She is literally using the wrong probe. And if I recall all the previous ultrasounds when checking for lung sliding, going all the way back to season 1, we're all done with the linear transducer. If, I went back maybe 1 or 2 could have been an abdominal probe that they used, but I don't think so. I'm pretty sure they were all linear transducers that they used. It's just in this case, used the wrong probe, so that kind of, the consulting physicians missed it, or somebody missed this, that she just grabbed the wrong thing. Very subtle detail, but I told you the point of my channel is to critique down to the smallest of details as if the PITT was real. And we're gonna continue to do that every single time. I would say this would be equivalent to like, what I mentioned before in season 1, you're intubating, for example, let's say it's a glide scope and you have a rigid stylet and you're intubating and you have a soft stylet in the ET tube. Well, that makes no sense. Like if you're going to do a glide scope intubation, you have a rigid stylet, and so it's one of those where they've got that right so far that we've seen. There's a few times, obviously, in season 1 it was wrong, but so far, those kind of procedures have been correct in season 2. And I think if you're gonna get a detail like that, then you should probably get the detail correct in terms of what transducer you're gonna be utilizing to check for lung sliding.
Bullet.
Oh, Royal Enfield, ankle breaker, thumper.
BP 138/80, pulse 94, pulse ox 98.
All your vitals sound really good, Brandon. They call it an ankle breaker because they got to kick over a big fat single cylinder to get it started, sometimes 5 or 6 kicks.
Especially on a cold day.
Does anyone have any trauma scissors? I'll check the knee.
Not yet.
Why not?
Dr. Santos?
Primary survey means rule out the life threats. Don't get distracted by lacerations or fractures. No free fluid in the belly.
Airway, breathing, circulation are fine.
Okay, that's ABC. That just leaves 2 letters. Tell her about D, Dr. Santos.
Disability. Wiggle your toes, sir.
Any pain in your arms or legs? Not really. Does it hurt when I push here? No. Okay, no midline tenderness, nexus negative.
No obvious brain injury or spinal cord injury.
I love that they're discussing the primary survey here. The only reason I am pausing though is because Whitaker states nexus negative. You will notice his hands on the C-collar and he goes, does it hurt when I push here? Nexus is basically a set of criteria to decide which trauma patients do not require imaging of the spine and which ones do require imaging of the spine. Patients have to meet certain criteria. I'll utilize both the Nexus and Canadian C-spine criteria together. A lot of your traumas, regardless, you're going to CT their cervical spine, so it's a little bit different. But is the patient, are they alert? Are they stable? Are there any deficits? Are they altered? Are they intoxicated or not? Was there a distracting injury? any midline spinal tenderness. These are criteria that we're looking at. Sometimes you can argue age of the patient, a few other things, but these are things that we're looking at. Whitaker actually never assessed that at all. When that C-collar is on, you can't feel the C-spine the way that he is doing that. You can't do that. When the C-collar is on, you cannot feel the C-spine that way. When you log roll the patient, you're gonna actually look at the spine. You can get your hands in there. There's a few openings where you can get your hands in there and you can actually feel along that. You'll get through the main hole in the C-spine itself, or the main hole at least in the C-collar, you can put your hands in and you can have a push. When it comes to like the bottom part of the cervical spine, like when you start hitting C5, C6, then you go underneath the C-collar and you can actually have a push on that. But you do that when you log roll. You don't do that before you log roll because you can't get an accurate assessment like that. What Whitaker did was actually an inappropriate way to check for midline spinal tenderness. It is not recommended, but it looks great for TV. It's just not realistic.
That just leaves E, Joy.
Can I buy another vowel?
Exposed.
Dr. Whitaker.
Exposure.
AKA strip and flip. Cut off his clothes and we'll log roll him. What do we have? Helmeted motorcycle acrobat, 8-foot falls, standing on top of 5 riders. Primary survey normal, EFAS negative.
Another motorcycle accident.
Hello, sir. I'm Dr. Garcia from surgery.
Hello.
Okay, we will roll him in 3, 2, 1.
All my fellow ER docs are gonna know exactly why I paused here. Probably all my ER nurses are gonna know why I paused here as well. Small detail, but I told you I was gonna point out everything. When you log roll a trauma patient, do you know who counts? Do you know who is in charge of the roll? It doesn't matter if it's a nurse or physician. Whoever is at the head of the bed, whoever has the C-spine is the one who is calling that. Whoever is at the head of the bed, you're the one in charge of that roll. The other person will never, and I mean will never, be in charge of the roll. This particular patient seems like Santos, yeah, it's her case, and she's in charge, but Whitaker has the C-spine. He's at the head of the bed. He's the one calling it 1, 2, 3, turn. So yesterday, for example, had a trauma patient. You're doing a log roll. So we got me down, I'm down there, trauma surgery's down there. I'm actually helping log roll the patient, and then we have a nurse at the head of the bed. And so when we do that, we're going on her. Typically, you're gonna have a nurse, tech doctor, whoever it is, you're gonna have one on the shoulder, you're gonna have one on the hip, and then you tell the patient that you're going to roll them. They're not gonna do that. And then you have someone got C-spine. So really, to get a good roll, you got 3 people. And you're gonna roll that patient. Whoever has C-spine, in this case, is actually one of the ER nurses. She's gonna say, all right, everybody ready? 1, 2, 3. And then you roll that patient up. And then I'm actually having a push, checking the C-spine, thoracic, lumbar, any step-offs, any abnormality. And in this particular case, given the situation, it was also a rectal exam looking for rectal tone and things like that. So it was a bad trauma 1. But that's what you're doing. And so whoever is at the head of the bed, you're the one that is counting. You're not doing it based on everybody else. And so that's the big thing with this. If you have a C-collar on, it means that there's the potential for cervical injury. You have a high enough suspicion for cervical injury that you have that C-collar on. So you have a high index of suspicion and you just don't want to remove it. So what that means is that at least until the imaging comes back and you can clear that patient, when you log roll that patient, everything needs to be done at the same time, with the head and neck actually the most important. If the person at the head of the bed is not ready, you can imagine head of the bed not ready, and then you start rotating that patient and then you try to catch up with the head, you can cause further damage, even with the C-spine. And so that's why the person at the head of the bed is actually in charge. Even though this is maybe Santos' case, Whitaker would be counting. That is standard within trauma assessment and evaluation.
Well, I grew up a block from Carrick, but my mom was a teacher at Brashear, so I had to go there.
The bullets?
That's right. But they were the Bullets when I was there. They changed to the Bulls when I left.
Oh. Hey, you think I could get something to eat?
Gus here's wondering if he's clear to eat.
As long as it's a liquid diet.
We have the results of your CT scan.
Your jaw should heal without surgery, which is good news, but it will be a few weeks.
Before I can eat?
Solid foods, yes. Or you can have food pureed with liquid in a blender.
I don't have a blender.
Right. Sorry.
We have a calorie-rich supplement drink called Ensure. Comes in chocolate, vanilla, or strawberry.
Chocolate, please.
Good choice.
How many can I have?
2 a day is recommended.
I'll get it for you.
You have an appetite. It's good.
Mr. Varney, your blood tests indicate low levels of protein and vitamins. Can we ask you a few questions about your diet?
Which vitamins? We don't order those in the ER.
How many meals or snacks do you have in a 24-hour period?
I don't know. Don't count. Pretty sure it's 3 trays a day.
We do not check vitamins in the emergency department. That is a myth. That is not considered an emergent test. If the patient was admitted, however, it can be done then. We have to see it here, I guess, because, we want to demonstrate that neglect, that malnutrition at the jail. We want all the drama associated with that. But we don't need labs in the ER to actually show this. Now, we see that in the PITT, again, for the drama, but we can actually see that without getting the vitamin levels. These are not ER tests. This is not standard of care in the emergency department to check vitamin levels. Like, we don't do that. I can already tell you he's malnourished. He's clearly dehydrated. He's got dry oral mucosa. The guy is very skinny. BMI is low. You can already tell he's malnourished. There's always the potential for neglect. Now, you get the labs at that point. You're looking for, okay, is the sodium low? Is there a sodium abnormality? Is there a potassium abnormality? Is there a magnesium abnormality? Is there a kidney injury? These are all things that we get back right away. A lot of your vitamins don't even come back right away. And these aren't standard labs that you get in the ER. You already have enough lab-wise to show the malnutrition, in terms of the neglect, obviously you'd have to make a few phone calls and things like that, but you have enough to admit that patient. But what do we see in the PITT? Let's just keep them in the ER as long as we can. Let's order all these tests that we don't normally do in real life. But it just doesn't happen. Like, we're not going to do that. Now, in combination with the patient's jaw fracture, this is an easy admit to the hospitalist and residency team. You have a patient that is malnourished, dry oral mucosa, likely has a sodium abnormality. It's probably likely a hypovolemic hyponatremia in combination with now a jaw fracture. This is an easy admit. You call the hospitalist for this, they're going to take this patient. We admit that patient. Now, in the PITT, let's pretend to check vitamin levels. Let's order non-ER test. Let's get the results back super fast, and let's discuss them. In real life, we're not going to do that. We're going to be admitting this patient. Now, once that patient's admitted, at that point, the hospital is going to order all these additional lab tests. That's completely normal. That's what happens. And it's going to be based on the clinical presentation, the patient's history, what they're concerned about. But there's a number of tests that the hospitalist is going to order that we don't order in the ER. And so I think that is a common misconception. I will say probably the number one drama that I see inaccurate right now, and I've watched a lot, is probably Chicago Med. The amount of stuff that they order in the ER in terms of making it seem like a ER test, and it's not. It's a order that's done as a hospital. Like, once the patient's admitted, the hospitalist is ordering that. I will say Chicago Med is probably the worst. Watching a few episodes of that, and it's just like numerous things, and you're like, you wouldn't really order this. If you're going to advertise realistic, you wouldn't order this. You wouldn't order this. Like, why are you guys ordering this? And so in this particular PITT case, this patient's getting admitted. The admitting team's going to order vitamin levels. That's just what's going to be done.
How often do you eat cereals, fruits, or vegetables?
Not many fruits and vegetables in prison.
Slow and steady. What year is your Bonneville?
69. Rescued her from a motor graveyard and brought her back to life with a buddy of mine who's supposed to be coming in today.
How often do you ride?
I ride it into work every day.
Good for you.
Don't encourage him. CT's ready for Brandon. As soon as we take a look at this knee.
Whoa. Through the deep fascia.
How's it look?
Definitely gonna need stitches.
How many?
It's going to need a CAT scan.
It could be an open joint.
We'll do a saline load after CT.
No, you won't.
Lever sign negative, ACL intact.
Okay, ready to roll.
Oh, I really hope that they do this saline load test. I will critique it hard. I'm going to call this out for sure. Whitaker did not need to do all that manipulation of the knee without any imaging. That makes no sense. A resident is not going to do this. Heaven forbid the patient's got all these different fractures, distal, femur. He's got all these fractures, and then you just start manipulating the leg. Like, you're not going to do this. Radiology is ready. So the patient is ready to go to CAT scan. The patient is literally going to CT scan. In real life, with a laceration that large and likely joint involvement, I can already tell you, you have a laceration that size, there's joint involvement until proven otherwise. And it's likely going to need ortho, it's going to need the OR, it's going to need a washout. In real life, if you have a laceration like that, the patient's going to CAT scan, we're going to order a CT of the knee. That's what's going to be done. The patient's already going for their trauma scans. You're going to add on a CT knee. CT scans are superior. They are 100% sensitive compared to the saline load test for diagnosing a traumatic knee arthrotomy. The CT scan can show intra-articular air, and it does not require an injection. If they go down the saline load test, there's a few different ways to do that and things that you can utilize for that. I'm going to critique it. I love this procedure as a resident. I've taught this procedure. If they go down this route, I will critique it hard for 100% accuracy and for 100% realism. Any deviation from 100% accuracy is going to be called out every single time. Now, what will the PITT do in this case? Skip the CT, which is the best study? Probably. They're not going to CT this knee at all. The patient is literally going to CAT scan already. Just add it on. It doesn't add much more time, but we know the PITT is going to skip the better test of the knee, and they're going to do a saline load to check for joint involvement. This is too predictable. Someone may say, well, Dr. Taylor, they're getting 4 trauma scans. Adding a knee CT to that is a 5th scan. All of that radiation. If they go down the saline load test route, I'm going to critique it as I doubt it will be done correctly. And you're going to see just why we actually CAT scan this patient in real life. Unless, of course, you're doing the test 100% correctly, which I doubt, but if they do it 100% correctly, that'll be fine. I'll see, if you want to skip the CT, you want to put the patient through the saline load test, the test is done 100% correct, and you have ruled it out, fine. Ortho's probably still going to ask you for the CT, I'm just saying. But if they do that correctly, okay. I dare you, PITT. Do the injection test. I guarantee it will be done wrong. Having taught this procedure, I guarantee it will be done wrong. And we can discuss the false negatives of this test. Please do the saline load test. That backboard would already be with EMS. Patient would be off it.
Are you still coming over tonight?
Small detail, come on guys.
He's going to be playing Farm Boy again this weekend, so he's not going to be around. I may need a rain check.
Hey, do you have an update on that neck patch patient?
Last I heard, Miller was doing an above-the-knee amputation with ortho.
Seriously? Oh.
Langdon's waitress with the cellulitis?
Yeah.
Man, that took a turn.
Sure did.
Yeah, it'll be a lawsuit.
Hey, did you hear about Louis?
Yeah.
You okay?
One of my uncles drank himself to death. Barely recognized him at the end. At least Louis always seemed happy.
I'm here if you want to talk.
They're not fighting in here. Still anyone's lunch, it's a $20 fine. Made a lot of changes while you were gone.
I can see that.
Is that a LaCroix?
I'll let you hide out a little bit longer, but then I need you to pick up more patients. You're not as fast as you used to be. Damn donut.
I love a good LaCroix.
Ouch. First day back, I get kicked in the nuts. One dead, one septic bounce back.
Both of those not your fault. Expecting a party?
No, not really. Didn't hear from anyone while I was gone.
Sorry.
They ever, arrest that guy who punched you?
Yeah. Wanted to know if I want to press charges, but didn't want to go through all that. Thought I was done. Really did, but
I was trying to see what kind of LaCroix that is.
only lasted
I think it's a
few weeks.
pamplemousse.
Yeah?
10 months is a long time to be alone with your thoughts. Almost lost everything.
With a
A lot of
Raz,
women
there's
would've
another one.
taken the kids and left,
Raspberry, raspberry, something Raz.
Abby stayed.
Because she's a good woman. Because you deserve a second chance.
I'm not sure everyone agrees with you.
Give it time.
Look, I've been working the 12 steps, trying to make amends. I was really selfish. I lied to myself and I lied to you. I'm really
You
sorry.
can check me off your list, kid. We're good.
Okay?
Yeah. Got a lovely patient for you in, too. Let's get you back on the horse.
Really need to talk with Robbie.
Enough today's the best day for that. He leaves on vacation tomorrow. Let him get to the day in peace.
He's supposed to be gone for 3 months.
So he says. I give him 1. Go get him, kid.
Dr. Langdon, this is Rocky.
Great name. What brings you in, Rocky?
Very sick.
When did it start?
An hour ago.
After he won a hot dog eating contest.
A hot dog eating contest. How many you eat? 351 hot dogs? 36. Still a lot.
Wow, eating 36 hot dogs. Already the sodium content alone could potentially give you severe dehydration, but life-threatening hypernatremia as well. Severe stomach pain, potential for perforation is always there, and obstruction are all possibilities after eating 36 hot dogs.
I pulled Zofran.
Go for it.
All right, this should help. Stick it under your tongue, let it dissolve.
Okay. Are you taking any
Santos, what's up with your Ilias patient?
Admitted to medicine, and before you ask, 13 has been discharged.
Great. 12 needs a doctor. No, don't make me go back there. That disinfection left just smells.
See that patient or go home?
So grab some coffee grounds from the lounge.
We need to admit our incarcerated patient, Gus.
What did the CT show?
Moderate pulmonary contusion, 3 rib fractures, no intra-abdominal bleeding, and oblique fracture in the body of the mandible anterior to the angle.
All favorable for healing. What's the treatment plan?
A pain medication, antibiotics, liquid diet, pulse ox a few times a day, and then also dressing changes for the laceration.
Which he can get at his correctional facility.
Or he stays here for a few days and we get him on the right track to healing.
Why don't you two go check on your patients?
Sure thing.
I actually agree with Dr. Al-Hashimi here. This case is now more than malnutrition, dehydration. You now have rib fractures and a pulmonary contusion and a jaw fracture. Easy admit, very realistic to admit them. Nobody would argue on an admission like this. I have a patient that is malnourished, dry oral mucosa, likely has a hypovolemic hyponatremia, potentially an AKI. They have a jaw fracture, they have pulmonary contusion, rib fracture. Like, there's so much stuff there. This is an easy admit. Great job, Dr. Al-Hashimi. Great job. I actually never thought I would say that. Wow. Great job, Dr. Al-Hashimi. Oh, how about that? I really said that.
What am I missing?
He's not getting enough to eat at his correctional facility. The portions are tiny, too many carbs, not enough fruits or vegetables. He's lucky he hasn't developed a chronic illness.
We don't have any inpatient beds. He would board down here for 3 days. We're still getting runs from Westbridge, and we cannot tie up behavioral for that long.
Dr. Al-Hashimi, Dr. Jefferson wants to talk to you about our tasered kid.
Why don't I call the prison doctor and find out what they're working with over there?
Thank you.
My pleasure.
What do you say, kid? Ready to go home?
How's your pain, Mrs. Hamler?
It's the same.
We're gonna write you a script for Keppra. You'll take that to prevent seizures once a day starting tomorrow.
Typically it's
Between your
twice a
broken
day.
leg and the bruises from your seizure, the pain will probably get a little worse.
Yeah, the most important thing is to let others help you. You'll need assistance showering and getting to the bathroom.
Yeah, no problem. I won't leave her side.
Oh, you need a break. You're taking care of me, the kids, the house. It's too much for one person.
I'm not the one battling cancer.
Aw.
Hey, you're in pain every day, fighting for your life. I'm happy to do this for you. You're my wife. Now let's go home and forget this day ever happened.
I'll call the transfer ambulance.
Thanks, Princess. Hey. Why don't you go ahead?
What?
Yeah, you can get the house ready. I'll be right behind you.
No. No, I'm riding in the back with you.
Yeah, I'll stay with her.
You sure? Okay. Call me if you need me. Come back.
I'm already starting to get the vibe at this point. It's not that the pain is still there. I don't think she wants to die at home. She knows that she is close, knows that it would be harder for the kids and family for her to die at home. It's as if she would rather stay in the hospital for that to happen. Before my mom passed away while in hospice, she was in the hospital just like this.
Short of breath? Yeah, I was worried the clot in my leg could have gone up to my lungs.
You're on Eliquis. That shouldn't happen.
This potentially could be a good case. The patient has a history of a DVT. They came in for shortness of breath. So the worry here is, does the patient have a PE or a pulmonary embolism in the lungs? He goes, you're on Eliquis, so it should not happen. Just realize while it shouldn't happen, it can happen and it does happen. Don't assume that because a patient is on Eliquis, they can't fail Eliquis. A patient can be on Eliquis, they could fail it. They could be on Coumadin, they fail it. They can be on Xarelto and they fail it. It happens. It shouldn't, but it happens. And so I think my most recent case was maybe 2 to 3 weeks ago, somewhere in there. Patient was taking Coumadin religiously. They never missed a dose. They had a history of a DVT. They came in with leg swelling, leg pain. They were tachycardic. High risk, obviously, so we're not going to dimer that patient. We did a Doppler, it showed a DVT, and we got a CTA of the chest, showed extensive clot burden within the pulmonary artery. The patient was taken to IR for a thrombectomy. The mistake in these cases is to assume that just because the patient's on anticoagulation, that they can't fail anticoagulation. They can still develop a DVT, they can still develop a PE. This is how mistakes happen when you assume. And is that where this case is going to go? I have no idea. But to present it this way, I'm like, I've seen this happen before.
Yeah, I know.
Donnie, I got this. Don't worry, Mr. Francis. I'll order the D-dimer. I'll be back to see you.
Wait, what?
Thank you, Dr. Mohan.
You know, I'm an MP now. I can pick up a patient with dyspnea.
I'm sorry. I've seen him before, and he's asked for me.
Why even order the test? He's on Eliquis.
Mr. Francis comes in every month and always asks for a D-dimer. He's worried, and it puts his mind at ease.
Oh, I
Why
will
not?
destroy this case.
Yeah, okay.
Donnie's the best. You learn a lot from him.
That's right.
Okay, so a few things with this. Clearly, this is a frequent flyer. They're anxious. They come in every month asking for a D-dimer. That is the part that I'm cautioning, is the fact that Dr. Mohan is doing a lot of assuming here. She is assuming that because this patient is a frequent flyer, they're only here for this test and that they don't have a PE. You're going to notice Dr. Mohan never got a history. She never did a physical exam. She never looked at the leg. He has a history of a DVT. If she questioned further, maybe he would admit to non-compliance with his anticoagulation. Or maybe he's like, you know, doc, if she would have asked, I'm having this leg swelling now in my left leg. I know I'm in here all the time, and I know I always ask for a D-dimer, but I've got leg swelling in that leg now. If she would have asked that question at that point, the patient's high risk, you wouldn't have dimered that patient. You have unilateral leg swelling, history of a clot, like you're just gonna Doppler that leg. But she didn't get any of the history. So maybe he's compliant if she just looked at the leg and she looks at it and she's like, oh, that leg is twice as big. There's basically an anaconda in his left leg. The whole leg is a DVT. But she didn't even look. She doesn't know. She completely passed him off here. And knowing the PITT, I'm predicting she missed this. The patient is going to have a worst case scenario type situation. The patient is going to have a DVT. That DVT is going to travel to the lungs. They're going to have a pulmonary embolism. They're going to go into obstructive shock. They're going to go into cardiac arrest. If they do, I'm going to talk about this case heavily, as I have a few publications on pulmonary emboli, the treatment, and things like that. I was even in the news for a short period of time when a patient actually told her story publicly for the world after being dead for 40 minutes with a pulmonary embolism, and my team and I got a heartbeat back. She went on to graduate from Ball State University with a master's degree. That's how awesome that case is. In the future, I've talked about this in previous episodes. In the future, I want to have her on and we'll just kind of talk about the case. But she told her story publicly for the world, which is why HIPAA is not an issue. That article generated millions of views worldwide. There are a multitude of news outlets that talked about it live. We were both on the news. Fox News was one. There's a lot of different outlets we were on at the time because it was a big deal. You had a young college patient that was dead for 40 minutes, and made a complete recovery. So if they go down a pulmonary embolism route with this case, I will talk about that case specifically. But overall, what Dr. Mohan is doing is a bad mistake. It's a poor decision, especially coming from a senior resident.
Fill me in. This is hologram. She was seen in triage. CBC and CMP came back normal. IT was supposed to bring the VRI down, but they're slammed. I know a bit of sign language.
IT was supposed to bring the VRI down. That stands for Video Remote Interpreting. Previous critiques dealing with this patient, I've talked about MARTI. Literally, it's this small monitor. You wheel it into a room. You choose the language. It doesn't matter if it's sign language or another language. It doesn't matter. You choose what it is. Even some of your rare languages you don't see a lot of, you're gonna find in there. Sometimes it may take you longer to get to it, but literally every language is on there and it's awesome. And you're gonna wheel the MARTI into the room. Eventually, you're gonna get that interpreter. Now, this patient has been in the waiting room for over 5 hours now. Is that right? 5 hours now, plus however long in the actual ER with no adequate translator. Why is this unrealistic? For starters, the size of this ER alone makes this situation unrealistic. That VRI wouldn't, it'd already be in the ER. The bigger ERs have a minimum of 1 in the emergency room, sometimes 2. All the ERs I work at have 2. The fact that this VRI is with IT or in the IT department and they can't bring it down because they're slammed. Now, maybe that they have to do, the fact that they're slammed and it's in IT has to do with the other hospital having tech issues. I have no idea. But the fact that they're slammed and can't bring it down, that's not an excuse. They never said it was broken. They just couldn't bring it down because they're slammed. Like, a tech can go up there. A resident can go up there. Somebody can go up there and get that. Send Ogilvy. He can go grab it. So that's the part that doesn't make sense. I think overall what they're doing for this patient is inappropriate and it's unprofessional on so many levels. She deserves better care than this. I just don't believe it is realistic with an ER this size that they don't have a VRI in the ER, that it's with IT and that IT is too busy to bring it down. When again, a nurse, a tech, somebody can go get it, med stu can go get it, somebody can go get this. All of that just makes no sense, but we need it to happen for the drama to follow. I'm sure I have no idea where this is going, but obviously it's gonna be dramatic. If the pattern continues, obviously it's gonna turn into something crazy, hence season 1 with the guy that punched Dana, I forget his name offhand. Shoot, what was his name? Doug Driscoll. And so, the case with Doug Driscoll, he made it all of season 1, and the issue happened. In this particular patient, we're seeing literally in every single episode, so I don't know what's gonna happen with that. But if this pattern continues, obviously something bad's gonna happen, but it shouldn't have happened, and it should not happen at all if we would be addressing the biggest barrier of this entire case at the beginning of this, like literally from her ER visit, with registration. And the secretary at the front desk, it was skipped from that part. This whole thing is really bad, and I hope that this patient ends up okay, regardless of what happens.
Hello, this is Dr. Santos.
Hi, Harlow. How are you feeling?
She has a headache.
Okay, what else? What is she saying?
I think she had a stomach ache and she might have passed out. I'm not 100% sure.
Okay, we're just gonna need to wait for an interpreter because I need to ask a million questions and I can't do it this way. So just call me when IT comes down.
No. Call me when IT is down. No, how about you go get the translator or send someone to go get the translator, get the computer, get the device, get whatever it is. Santos blowing her off is sad. It's not appropriate at all. If IT cannot bring it down, then go get it. I don't understand why someone will not go get it. This is crazy. You've had multitude of hours to go get this. If something was to happen, this could honestly be a lawsuit case as well, because they can't use the, IT was too busy because someone could have went to go get it. So that won't be an issue. The delay of care of this patient is alarming, and we've talked about the delay of care of certain cases. So this one could be a potential lawsuit as well. We have not heard that it was broken, only that IT was too slammed to bring it down. So clearly they have it. The ER needs to send somebody to go get it.
CT head, neck, chest, abdomen, pelvis, all negative.
It means we can get this collar off. Thank you. Yeah, roll to your side. We'll get you off this board.
Should have been off the board already.
How long's your trip? 2,000 miles, all the way from here to Alberta. A couple stops along the way. Got the whole thing mapped out?
Sounds like heaven.
Let's hit you up.
Turn the patient so that they can take out the board. Only detail with that is that when the patient came in, the board would be taken out when you're doing the log roll. When the patient came in, they were on the EMS backboard. When we rotate that patient, it's gonna come out. When they go to CAT scan, that board is not with them at all. You're not sliding an EMS board onto the CT table. You're not gonna do that. That patient would not still be on the backboard going to CAT scan. Makes zero sense. We don't do that. I think it was missed in this case. In fact, actually, the reason that board comes off is because, one, it's painful, it's kind of discomfort, like you're laying on it, it's flat, it hurts, but because that board actually belongs to EMS. Before EMS leaves, they're literally gonna say, hey, where's our board? They won't leave without that. They need that board, they're gonna clean it off, they're gonna use it for the next patient. We don't keep that in the ER. When the details of this case were reviewed, I'm not sure who missed the detail of taking the board out now, but it was missed. Come on, guys.
Sorry, I got stuck with a patient.
You know the old saying, 4 wheels move the body, 2 wheels move the soul. You're gonna be living the dream.
Thank you, Brandon. Not everybody down here feels that way. Okay, Whitaker, what's next?
Ortho assessment. Palpate all long bones, starting with the clavicle.
Got it. We'll take the lower extremities.
They still haven't did any x-rays of the knee. Santos just moves the leg. In real life, especially in a trauma, at a minimum with a laceration like this, you're not just gonna start moving the knee. We've talked about that with Whitaker. You're at least gonna have an x-ray before you start manipulating it. Heaven forbid a fracture and you just moved it. Or you had a non-displace, you manipulated it, now it is displaced. So we talked about that already, I'm not gonna get into that. But since this patient was in CT scan, we honestly would have just CT'd the knee already. But you sure aren't gonna start moving it abruptly like that without any imaging at all. Now in the PITT, this patient isn't gonna have a fracture at all. But in real life, guess what? That patient's gonna have a small fracture. They're gonna cuss, they're gonna swear because you're moving the leg and they have a fracture. Why? Because I did that as an intern and moved the leg without an x-ray. Again, in the PITT, there's not gonna be a fracture. In real life, you better believe me, there's gonna be a fracture.
Distal radius tender, no deformities, needs an x-ray.
No bony tenderness down here, no laxity of the knee.
Any concern about that knee leg?
Yes?
If it's an open joint, he'll need a washout in the OR.
We could try a fluorescein injection. Okay, we'll need a wood slam.
1% lighter with epi, sterile saline, sterile basin, sterile fluoro strip, 18 and 27 gauge needles, 5 and 60 cc syringes.
Nurses know their
I
stuff.
actually know all that.
She just does.
How we feeling, Rocky?
Oh, much better. He's had 8 mgs of ondansetron. Any pain in the belly?
No, but my mouth is really dry.
No doubt from consuming mass quantities of salty hot dogs.
Can I have another sip of water?
Sure, little sip. Take it slow.
Here you go.
Thank you. Just enough to wet your whistle. So, how'd you get your start as a competitive eater?
It's got that hot dog consistency, that pink, blah. Just looks processed.
Any pain here, Mr. Lee?
Can't feel a thing.
Great.
Where's Santos?
Probably catching up on her charting.
Right.
That she should be doing
Right side,
not in
wood
the
slam
ER.
on. Okay.
You might want to use some of that on Halloween.
That is 250 cc's of sterile saline with 1 small touch of a sterile floor strip. We are going to inject this fluid into your knee, Brandon, and if there's anything glowing in your wound, we know we have a leak.
Feeling some pressure.
Yeah, it's normal. As soon as I finish the test, I'll pull off the fluid.
That looks good. Laceration did not enter into the joint space.
Surgery not needed.
Excellent. I can get back to the parade. No, we'll still need to stitch you up and splint your wrist.
Well, we called this one. It is a saline load test, but it's been modified a little bit just to help with visualization. They're doing a saline injection into the knee, but they're adding the fluorescein stain. It's actually the same stain that we use when we look for corneal abrasions within the eye. So similar concept, they're just kind of taking it a step further, making it easier, which is honestly is a pretty smart move. They're utilizing the stain and a light to actually help. With the saline load test, you're injecting saline into that joint and you want to see if it comes out the laceration. For your standard saline injections where you're not adding fluorescein, you're injecting enough saline basically to watch it kind of bubble out the top. You want to see when you put the needle in and start injecting, does it actually come out the laceration or not? By adding the fluorescein stain, you actually use a light, you flip the light off, and you can actually see the actual stain. It makes it much easier, especially if the wound itself is large, there's a lot of blood, and you're like, I think that's saline coming out, but I'm not positive. Flip the light off and you have fluorescein stain, you're gonna be able to see it. There's not gonna be a question. So nothing wrong with that. Now they give the mixture in terms of saline to the actual fluorescein stain, the ratio of one to the other, but really the part that we don't get to see is how much of the actual syringe are they injecting? Like how much volume are you putting in the knee itself? You can imagine if you got a laceration in communication with the joint space and I inject 10 cc's of normal saline, you're not gonna force anything out. Like the saline is just gonna sit in the knee. You need enough pressure in there. You need enough fluid in there, enough saline in there to see if it comes out of the laceration. And so you can see why 10 cc's actually isn't enough. Acute care journals and emergency medical journals recommend anywhere between 100 to 200 mils injected into the knee itself. I like 150. You can visualize how much fluid that is. Obviously, it depends on what's the size of the patient, what's the size of the joint. The key with this procedure is putting enough saline in the joint so you don't end up with a false negative. If you don't put enough in there, you haven't ruled out anything. And so, again, all the evidence will support anywhere between 100 to 200, and that depends on the size of the patient and things like that. So the question becomes, did they utilize enough here? Now, in this particular case, I couldn't tell the size of that syringe. It looked like maybe a 60 cc syringe. It's hard to tell, but regardless, I can tell you for a guy that size, in a joint like that, they didn't put enough saline in there. The recommended, again, is 100 to 200 mils, and this is per multitude of medical journals, acute care journals, emergency journals. This is the recommendation. That is evidence-based medicine, and they're putting a 60 cc syringe. It looked like it was only one syringe. The result's going to be a false negative read, and you never ruled out anything at all. If you call ortho, I promise you, if you call ortho, seriously, call your ortho bro after you did a large laceration trauma. You chose not to CT them because you're dumb. And then you do your injection, you put 60 cc's in there, and you call ortho, and you're like, you explain the case, and you tell them you put 60 in there, and it's, there's no communication. Dude, you're gonna get chewed out. Like, that's crazy. You didn't rule out anything at all. You just didn't put enough in there. So since the PITT did not inject enough into the joint, this is going to be a false negative. And now you just opened yourself up to, guess what, a potentially missed diagnosis. You're going to end up closing, the laceration up. You never ruled out anything. You're closing it up, and the patient should have been taken to the OR with ortho for a complete washout. But because you used 60 cc's, you didn't use enough, you got a false negative. This is crazy. Like, I called this from the beginning. I was going to call it out. These things typically do not get done correctly. Now, if he would have said in passing, all right, let's go ahead and inject the second syringe, I would have been like, boom, it's between 100 and 200, it's 120, it's solid. Oh, but guess what? Do you know how to be 100% sure that there's no joint involvement and you just didn't screw up? How about this? CT the knee. Guess what? You would have already had it back already. It'd already be done. Oh man, but we skipped it. Instead, we chose to manipulate the knee without imaging. We injected 60. We got a false negative. We didn't call ortho. This is crazy. If you inject 100 to 200 mils of saline, the patient is going to feel pressure. They're going to feel pain. They may even swear at you. You then confirm joint or no joint involvement because you put the appropriate amount in there. And then guess what? You actually have to drain it all back out as well. You don't leave it there. You have to drain it all back out. And then you're gonna call ortho, and ortho's probably gonna say, did you get a CAT scan at all? Well, no, I didn't get any imaging. You have a large laceration, no trauma imaging. What's to say that's not an open fracture? It's a large laceration above something. And now you just have an open fracture. It's like, there's so many issues with this case. I see what the PITT is trying to do, but let's make it realistic. Let's make it accurate. You at least got an x-ray, something. If you didn't do the x-ray, you at least did the CAT scan. Like if you still want to do the injection, that's cool, but maybe you did an x-ray, you prove there's no fracture, and then you do the saline load with the fluorescein, but then you put the appropriate amount in there, that's totally fine. And then you discussed it with ortho. There's so many things that could have been added to this case to make it 100% realistic, 100% accurate. It wasn't there.
Hanging a gram of Ansef.
Wait, he has a penicillin allergy.
No, Penfast was negative. We're okay.
My mom said I got a rash with amoxicillin when I was 2.
Yeah, probably not a true allergy.
That's exactly right.
But have Epi and Benadryl standing by, right?
Yes, to be on the safe side.
Most people who think they have a penicillin allergy actually
That's
don't.
so true.
Always listen to the nurses.
Preach.
They run the ER. We just try and stay out of their way.
I think Dr. Robbie said that in season 1.
Now we can really clean him up.
Didn't we already do that?
Dry blood on the face, neck, hands. If anyone comes, they shouldn't have to see that. Sometimes the local unhoused folks will pay a visit, but we always make them presentable in case anyone comes. It's the last thing we can do for them. Didn't get to do that during COVID. But once he's spotless, we'll tuck him in nice and tight, but we always leave one arm outside the sheet.
Because...
So loved ones can hold their hand.
This scene is very realistic. After a patient's been pronounced, similar to Louis, there can literally be blood everywhere. There's lines, there's tubes, the endotracheal tubes, the IV, the central line, the course, whatever the patient had, the blood is everywhere. It's just, sometimes it can be a mess, and the family is gonna be arriving. You don't want them seeing all that, so the patient's gonna be cleaned up. We're gonna bring in family. Sometimes in cases where it is a coroner's case, we let the family know that ahead of time. Hey, because you can clean the patient up, but you can't touch any of the tubes or anything. And so you're cleaning the patient up, but you let the family know, hey, this is a coroner's case. This is possible. There's a possibility it's a coroner's case. So you're going to see the endotracheal tube. You're going to see a few other tubes, not to be alarmed by that. And so it's completely normal to give them a heads up. Now, what the PITT could have done for Louis to make this realistic is Dana could have just passively mentioned, oh, Dr. Robbie already spoke with the coroner. It's not a coroner's case. Easy fix for this episode. I wouldn't have called it out. That would have been perfection. It would have made this case perfect, but it didn't happen.
We're ready to discharge our cancer mom, Roxy. Ambulance is on the way. We just need to reconcile with Homeless.
Hey, I thought I saw another charge nurse around here.
Oh, yeah, we travel in packs.
Aren't you sick of this place yet?
Someone is ready for his sabbatical.
Guilty as charged.
Hey, I just got word that the at-home morphine pump is going to be delayed. Hospital pharmacy has to mix it and then deliver it later today.
Well, should we keep her here until it's ready?
No, you can give her a 200 milligram tablet of Mescontin.
200 milligrams?
Biggest pill they make. Releases over 12 hours for patients with opiate tolerance.
The resident better not administer it.
And you want to stick around a little bit? Westbridge is close to internal disaster. We're getting all their runs.
Yeah, I heard. I put
She can
20
order
bucks on
it,
the
she just
plumbing
won't
issue.
give it.
I just watched that Poop Cruise documentary. Oh, I cannot stop thinking about it.
That sounds like something I will absolutely never watch.
Dr. Robbie, you gave us a clozapine alias about an hour ago.
Pausing here, I can see the tag. This is internal medicine. This is one of the hospitalists. We are seeing a hospitalist in the ER. This is awesome. It is a monumental moment. For the PITT to add certain specialties, like to see certain specialties in the ER, makes it realistic. I had a shift yesterday, saw cardiology in the ER, saw GI in the ER, and saw urology and pediatrics in the ER because they're seeing consults, they're seeing patients. Specialties that you won't see in the ER. I've never seen a plastic surgeon in the ER. I've seen cardiothoracic surgery. I've never seen a plastic surgeon in the ER. I've never seen, and these are large academic trauma centers, even with where I train, like you don't see them in the ER. If anything, you see a fellow. I've never seen infectious disease. I have never seen plastic surgery in the ER. Let's see here. I for sure have never seen dermatology in the ER. I have a friend that's a dermatologist, and I'm pretty sure they know what the ER is, but we don't see them in the ER. It doesn't happen. I'm trying to think of another specialty. Really, plastics, infectious disease in dermatology. I've actually never seen them in the ER. Anybody that's watching this, if you're in the ER and there's a specialty, you're like, I don't think I've ever seen them in the ER, feel free to drop a comment. I do love that the PITT is showing us internal medicine. This is perfect. It does add to that realistic nature. Now, a complication of what we just heard about, referring to a clozapine ileus, a complication of that medication has to do with the anticholinergic properties of that clozapine. That can actually lead to constipation and obstruction. Similar concept to a Benadryl overdose in terms of the anticholinergic toxicity. So you can end up with that constipation, obstruction, things like that. So I'm curious at where this is going to go. I really wish we got to hear this entire case. I would have loved to have picked it apart. We could have talked about this medication side effects, rare, but we could have talked about this medication side effect. But the PITT can only show us certain cases for the sake of time. And so this was just passively mentioned here.
Your resident reported no surgical history, but the chart says they've had an appendectomy. We're not admitting the patient without a surgery consult.
That means you didn't actually see the patient.
Dr. Santos, you had an ileus patient. You neglected to mention a history of appendectomy.
There was no history of appendectomy.
It was in your
But you didn't see the patient, otherwise you'd know that.
I may have forgotten to proof check it. I was using the app that Dr. Al-Hashimi suggested to catch up on my charting.
Wonderful.
Now, obviously in this case, the internal medicine attending is referencing, something in the chart that wasn't there, vice versa, something in the history that's not there. And it's getting back to that dictating AI software, rather it's going to generate something that is different, vice versa. The point here is that we're not signed off on our notes. Like, our notes are not signed, our notes are not finalized, they are shared, which means we're adding to them constantly. And then when we get some free time, we're going to review it. The internal medicine response actually to this entire situation's, it's a little over the top, in my opinion. I admitted a couple patients, on today's shift alone, so busy. I had some stuff in the chart. I had a little bit. It was just enough for the admit, and we quickly put a few sentences in so I can finish it later. But we review everything. And I will say, depending on your EMR, if you're using Epic or Cerner or a few things like that, when the chart is generated, it's actually automatically going to populate the patient's surgical history for you already. Now, if it doesn't generate that, obviously you have to ask for that particular history. And the reason it becomes an issue in this case is because we're dealing with an ileus. So, are we dealing with a history of surgeries? Are there adhesions? There's a lot of random other stuff. But I think that how the internal medicine attending responding is just, it's over the top.
Ah, Dr. Al-Hashimi.
Yes.
Dr. Santos was just using your AI tool for her charting, and it hallucinated a history of appendicitis.
As I mentioned to Dr. Santos, generative AI is not perfect. We still need to proofread every chart it creates.
The patient also has a history of headache, followed by Dr. Park from urology.
That should probably be neurology.
Unless urologists are now treating migraines.
Another example that should have been caught by proofreading. AI's 2% error rate is still better than dictation.
Yeah, I don't really give a shit whether or not you want to use robots down here. I need accurate information in the
See the
medical record.
patient. Holy cow.
Dr. Santos. Dr. Santos!
Yep, won't happen again.
Wait. In a minuto.
Thanks, Prilla.
6 hours to go. You got this.
Santos would have already have had this discussion with the hospitalist, and she would have reviewed with the hospitalist what was relevant. Now, in this case, we haven't reviewed what the note got, like what got generated by that technology. We gave you the relevant details of this case. We discussed the case with you on the phone. You accepted the admission. Today, for example, I had a diverticulitis case that I admitted. Now, I don't use AI. I use a Dragon dictation software. I talk into it, and then it generates exactly what I say. Now, sometimes it doesn't always do that, and I'll talk fast, and it picks up literally everything. But when I review my note later, I'll fix a few things. It said this instead of this, and that's technology of me literally talking into it. So I can imagine an AI software trying to pick up, is not going to be any better. But when I reviewed my note later, I had to make some changes. The way that this internal medicine hospitalist is mad regarding a history of an appy is just over the top. but it has to be done for that dramatic television appeal, given this entire season is essentially dealing with this, technology and kind of the back and forth. It's just, I would have wrote this scene a little bit different. I think what would have made this more accurate is if the I am attendee wasn't as over the top, because nobody's like this. No internal medicine is this over the top for this. This is crazy. If she would have been dialed back a little bit, Santos would have been ahead of the game. She finished her note, signs it, and then the hospitalist confronts her about it. Hey, I noticed you signed your chart, which has happened to me as a resident. Hey, I noticed you signed your chart. Actually, it happened to me as a resident, but then one of our mid-levels, it actually happened to them. They actually signed their chart on a consult, and you read the chart, and it said something about patient was given Rocephin, but they weren't given Rocephin, they were given a different antibiotic. And so they already signed their chart, so they had to actually go back in their chart and then change that antibiotic. So it's typically an addendum at that point, or it's a modification, and then it's to be notified of a modification. And so they had to make that change. And so that does happen. But if the hospitalist would have went up to her and said, I noticed that you signed your chart, you said this and this and this was a discussion with the patient, then she could have went back in and signed it, made an addendum. And you wouldn't have had this like really dramatic thing. Let's tell everybody and let's have the medicine. Like nobody responds like that. That's crazy. It's over the top. When I admit a patient, I have a partial chart done with a Dragon dictation software, or if I'm using a scribe, for example, I'm gonna let the hospital know, hey, the chart's in progress. I got enough in it, at least for the note. It's not been signed off yet. I haven't reviewed it yet, at least for accuracy, just so you know. They're fine with that. They don't come stomping down to the emergency room, getting aggressive with everybody, causing crazy drama. Nobody does this. It's how the PITT is portraying other specialties is, I think, the part that is really lacking in the PITT. Like, did you get a hospitalist for the PITT? Did you get a hospitalist for this particular part of the episode? I don't think so. Because yes, a hospitalist wants an accurate chart, but it also hasn't been signed. And the resident gave you everything that's needed. I would argue no hospital is going to come stomping down and cause crazy drama like this. This is over the top. Like, this is nuts. And I think a hospitalist would not have portrayed themselves like that.
Wound is gaping like this. You want to use sub-Q to bring the edges together.
A lot of meat to close.
Well, what would happen if we just did a simple wound closure?
You take the stitches out in 10 days, the wound opens, dehisces.
Exactly. So what suture do we use under the skin?
Vicryl provides support for a month. It takes 2 months to dissolve.
So 5-0 nylon on the skin, 4-0 Vicryl under the skin.
I go with a 3-0.
I would do a 4-0 Vicryl.
You think?
Most definitely.
Donnie is the master of wound closure.
I do at least 10 lakhs a day out at triage, so.
Can we see your sub-Q?
You my guest?
If you insist. So, the secret is to be sure your entry point and exit point on both sides of the wound matches the depth on the other side. So, start deep, come up at the dermis.
Big bites help the tissue close.
It's a mirror image on the other side.
I mean, that looks good.
Superficial to deep.
So you bury the knot.
Bingo.
Avoids bumps on the scar line.
3 ties. Not 4.
Yeah, that's beautiful. And then you cut it short, not too short.
I like to slide my scissors down on the knot and rotate up 45 degrees before I cut.
So good.
Can use 2 more sub-Qs, 1 above, 1 below. Have at it.
Interesting ink. Do they mean anything?
This is death and chaos, and this is miracles and blessings. Got this one after the Pit Fest shooting. And I got this after my daughter was born.
Put the head of the gurney up so people can see him, but not so high that his head flops to the side. What do you think?
He looks peaceful. What's the hardest part of this job?
It's pretty thankless, and that can be tough. You've seen the burnout rates. I'm sure they teach you that in school. All my closest friends left after COVID. Some during. But I don't blame them. They need to do what was best for their mental health. A lot of people broke.
Why do you keep coming back?
Why don't you, just finish up here and then go help Perla for a bit?
We come back for that chance to save a life, that it'll balance out everything else.
Great, thank you. No, that is exactly what I needed to know. Okay. I just got off the phone with the physician assistant at the prison. They've got a 16-hour-a-day infirmary with NP and PA coverage, giving everything that we need, and they've got an RN for overnights.
Even so, he's here because they're ignoring his basic needs.
He's here because somebody kicked the shit out of him.
I think you're missing the point. We have more to offer.
Robbie, got 4 more coming our way.
Okay, got it. What you're trying to do is very noble. We don't have the resources to spare.
Okay, then why admit the unhoused man, Digby? Why not send him back to the street with antibiotics and a roll of gauze?
Because Digby lives on the street, and your incarcerated patient has a mid-level provider and a nurse looking after him.
We both know the quality of care is not the same.
Sorry, you waiting for me?
No, Dr. Al-Shimi for the patient in 7.
A few days here could make a world of difference for Gus's health.
We are a safety net. But nets have holes. We are not admitting them because this is not about social justice.
You need to go away. Nobody wants you there.
Everything I've done in my career is an effort to improve the system. Just because you know it's broken doesn't mean you stop trying. Excuse me.
How's she doing?
She took 3 ounces of formula without vomiting or distress.
Excellent. Dr. Wolk from PITT should be done shortly.
I think I saw her smile.
A true social smile where the baby is awake, alert, and responding to facial expressions usually doesn't happen until 6 weeks or older. It was likely a reflex smile that happens while they're sleeping. But some parents have reported their baby smiled socially as early as 4 weeks. So, who knows?
Jesse, North Ford needs a blood draw when you have a sec.
Got it.
How we doing in here?
Almost ready to head out. Looking good. Heart rate 91, BP's 115/82, oxygen sats 95%.
Great.
I'm sending him home with some nonstick dressing in case they don't stock him.
Grab some Burnett, too.
He's a good guy. He's local.
Yeah? You from Pittsburgh?
Yes, ma'am. Born and raised.
Whereabouts?
Bloomfield. Liberty Ave.
Bloomfield. You know Sonny's Tavern?
Worked there through high school.
No kidding.
You know Sonny's?
I first kissed there.
Hey, Donnie, my buddy Duke hasn't checked in yet?
No, I told Lupe to keep an eye out.
Thank you.
Yep. Right, left, yeah.
Sir.
You back to check our work? Nope. I need a silastic loop drain. That looks great.
It's thanks to your fine instruction.
Yeah, he's gonna need Curlex and Zero Form.
You should throw a neoprene sleeve on him. Limits the range of motion at the knee so the sutures don't pull out.
That's a good idea.
Boom, I love this. That laceration is over the joint. If the patient flexes the leg, there's a good chance the sutures are gonna break. So we're gonna ace wrap that area. Sometimes we'll actually put them in a splint as well, and then you're gonna give the patient crutches. All of that would be appropriate in this situation. We don't want those sutures to break.
Must be fun to work here.
Oh, sure is. First week for these two. How you guys liking the pit?
I feel like I was born to do this.
No, you weren't.
Hard pass. I'm shooting for pathology. I like medical mysteries, but I don't really deal well with people.
You have an interest in energy.
What's that for? Splint starts at the knuckles, comes up and around the elbow, and back down to the palm.
Needs to be smaller. I can't ride with a splint.
Okay, so that's a subtle detail, but what Whitaker is doing, utilizing Curlex to measure how long the splint needed to be, that is so smart. I just used tape. I did more of these in residency because, as you know, in residency, all the residents would do them. As an attending, typically it's the ER techs that are going to be doing these. Obviously depends on your hospital and things like that. But as a resident, I would just use tape. I take tape and then I fold it in half, and then I'll measure exactly what needs done. So if it's like a posterior splint or I need stirrups around the ankle, something like that, I'm utilizing tape and fold it in half. Using Curlex in this situation is actually pretty smart. They're going to be using orthoglass material, so it's going to go on soft. Once you open that, it's eventually going to harden. It's going to get rock hard. And so it's going to go on soft, it's going to harden, and you want to know how much you need to cut, what the proper size is. Small detail, but Whitaker nailed it.
Well, no, you shouldn't be riding at all. Right now, that's a non-displaced fracture. If you fall on it again, you're gonna need to go to the OR.
No worries, Doc. I won't fall again.
Uh-huh.
Robbie, pulse ox just dropped.
What happened? I don't know. I stepped out for a minute.
It's down to 85%.
You having some trouble breathing?
A little.
Start him on 2 liters oxygen nasal cannula, titrate to 5, keep the pulse ox at 92 or higher, and have a rebreather standing by just in case.
85% on room air, short of breath, and now being placed on 2 liters nasal cannula. Likely it's the underlying pulmonary contusion that's causing this. Given he's on oxygen, he now for sure is getting admitted. You had reasons to admit him before, but now you really have reasons to admit him because he's on oxygen. Now, if that truly is the case, and the hypoxia is from that contusion, it means that the pulmonary contusion itself disrupted that alveolar capillary membrane. You get blood within the lungs, you get this ventilation perfusion mismatch, and the result is hypoxia and admission to the hospital. Now, what is weird about this is that Dana walks in, this happens, and then I'm like, did Dana do something? That entire situation's, it's kind of weird.
He's gonna have to stay.
For how long?
What did she do?
Not sure.
Sorry, boss. I only stepped out for a second.
Let me know if anything changes. You were in the room when his pulse ox dropped?
I was.
What were you doing?
Dee still can't get a hold of ortho.
Leave him to me.
She put tape on it.
Feeling better?
So much better.
Well, I wrote you a script for Zofran just in case.
Thanks. I think I cleared it all out.
So no more hot dogs, right?
Oh, not today. But I'll be back next year. Gotta defend my title.
Okay, well, best of luck to you.
They got a Wiener World truck outside. You want one?
I think I'm gonna hot dogs for the rest of my life. Wait, didn't I just see you eating a donut?
Don't judge.
Stay here for a sec. Transport ambulance is here. This is a 200 milligram MS cotton. This
Don't
will give you
administer
12
that
hours
yourself.
relief.
Seriously?
Whenever you're ready, Rox.
Hey guys, this is Roxy Hamler.
Hello, ma'am.
Well, I'm not even going to comment on that medication. I'm only commenting because we keep seeing doctors giving patients meds. Stop it. Stop it, Pitt. We don't even give our patients Tylenol, literally. Doctors don't even give their own patients Tylenol. We'll get the, if you're a good doctor, you're gonna get your patient water, occasionally ice, a blanket, kiddos a toy, sometimes a snack, things like that. If you're an awesome doc, you're gonna do those things. But we don't even give our patients medications. We don't give them Tylenol. We don't even give them Motrin. Stop it, Pitt. Please stop it.
Easy on the transfer, guys.
Yeah.
On my couch.
No. This isn't gonna work out. I'm sorry. I can't do this. I want to stay. Please. It's okay.
Can I assume that you've already called upstairs to get Gus Varney in bed? Do you want to tell me what you did?
I don't know what you're talking about.
Put tape on the pulse ox.
His pulse ox was steady. We were about to discharge him. Did Dr. Elishimi put you up to that?
Hell has Shimi now.
You know he's going to go back to prison after they discharge him upstairs.
Which would be weird because there was a good way for him.
I thought you didn't go the extra distance for your patients anymore.
It's Emma, right?
Yeah,
How's your first day going?
good, I think. Haven't killed anyone yet. I'm sorry.
It's okay.
I guess time will tell if I'm cut out for this.
Well, when in doubt, stick with her, kid.
She scares me.
No, that's just it's a tough exterior. She's warm and gooey on the inside.
Charge nurses will lay down the law.
Looks like they're doing the debrief for Louis.
You coming?
I'll pay my respects. Besides, just gonna hold down the fort.
Remember the day you found him passed out in the park?
Sure do. I had to drag his ass over here.
Came in soaked to the bone.
You saved his life. How about last summer when we didn't see him for months?
He said he finally quit drinking, so he didn't need to come in.
How many times did he say he was going to quit drinking?
He always asked about Harrison.
Always said thank you.
Found this with his stuff. Who knew he was married?
That's Rhonda, Louis' wife. High school sweetheart. About 5 years ago, I was covering a night shift. He came in feeling talkative. Born and raised in Pittsburgh, lifelong Steelers fan, groundskeeper at Three Rivers Stadium until 1998. He never really wanted kids. But Rhonda wore him down, and when she finally got pregnant, he changed his tune, he got excited. And then about a month before the baby was due, Rhonda and the baby were killed in a car crash. Louis never really came back from that.
Rest in peace, Louis. Rest in peace.
May his memory be a blessing.
His memory be a blessing.
Just a TV show, but man, that gets you. If you made it this far, thank you for watching. Critiquing episode 6 is a lot of fun. It didn't take nearly as long as the other episodes, but it was still a lot of fun. I'm headed to bed, I finished a shift, I did this critique, I need to go to bed because I'm doing a 12-hour ER shift. I need some sleep. My name is Dr. Taylor. Welcome to Dr. Taylor Reacts, and we'll see you next time for episode 7.